I'm going to close this off with a surprise presentation. We've switched from scopic to vascular, so I'm going to try to not make it too long because it's already pretty late and far later than we thought. I actually dedicated this presentation to my mentor. You heard him right now, and I think there are a couple of points we should take out here. I love the perforating arteries. That's one of my most beloved subjects in all of anatomy. And I've never given any presentation on the perforating arteries so far. And I've never seen, and this does not, I don't want this to sound arrogant, but I've never seen a presentation on the perforating arteries which was good. I've never seen a presentation on the perforating arteries which made you understand what the perforating arteries are, where they're going to, what you do with them, what are the infarcts. So what I'm trying to do is I'm not going to try to go in depth with this, because this is a subject which requires its own course of 3 to 5 days in order to know everything about this. There's been literature since the time of Duret. You probably heard about Duret bleedings in the brainstem. There was an amazing anatomist and pathologist who began writing about the vascularization of the thalamus, and that was about 1870. And since that time and up to this point, there are many studies which draw attention upon the perforators. And what I've heard so far, especially from neurosurgeon, is perforators, all the small arteries, just leave them alone and don't get it. But if you do a combined petrosal approach, in order to link it with that, one perforator will make hemiplegic. One, because of segmental distribution of the perforators in the brainstem. One perforator, one coagulation, one missed move of the scissors will make your patient hemiplegic. And it's not the only one that's problematic. We're going to see in the presentation. I'm going to try to make it as compact as possible, because you've been attended upon that it's a very complicated and very long presentation, so just try to bear with me here. So the basal perforators of the brain, if we're to divide it like this, there are 3 very important parts. The posterior fossa perforators, which go especially to the brainstem and to the cerebellum, which we're not going to be talking about in length today, because they're very complex, they have a lot of names. There are books that are dedicated only to them. Duvernois, 1978, Atlas of Human Brainstem Vessels. So that's not for today, I'm just going to give you an overview of that. The frontal perforators, which are coming from the ACOM, which we're talking about last, and the basal perforators. The basal perforators, as the name suggests, they go to the basal ganglia and to the basal substances of the brain. So you've got gray matter, you've got white matter underneath, you've got the insula, you've got the claustrum. We're going to be talking about that. And then you have the middle. What's in the middle? That's probably one of the most important structures for your patient. And those are the basal ganglia. And obviously you have the internal capsule, which is also very important, and the thalamus. And the thalamus can give such weird neurological deficits if you have infarctions there, or if you cause infarctions because of your coils or your operation, that you'll be surprised what it can give. So I'm going to be talking about basal perforators first. Now, if you get oriented here, you're going to see that this is the caudate nucleus. This is the thalamus on the posterior side. This is the internal capsule, the putamen, and head, tail, caudate, and amygdaloid body. Now, this is the splitting of the carotid artery, and we begin to understand the basal perforators with the recurrent artery of Hübner, which is coming out of A2, A1, A2 junction at the level of the ACOM, and which gives us these arteries, which are called the medial striate arteries, or the central medial striate perforators. The medial striate arteries are not to be confused with the lenticular striate arteries. You probably know about that, and some of you have probably seen Abdurov give a presentation, and he's always showing that same aneurysm which he's where he's peeling that lenticular stride off, and he's saying, yeah, you know, at the beginning I was taught that you have to see the aneurysm, make sure it doesn't rupture, clip it and get out. And now I'm trying to preserve every perforator, and that's what you should do. You should do fine, beautiful microsurgery in order to preserve every perforator, and that's even more important for the ACOM perforators, which you're saying, yeah, it's an ACOM aneurysm, it's I'm going to just clip it, and it's so simple. My mother could do it to quote Hennessy, but it's not. It's actually not. If you look at just at the subcallosal artery, which is one of the most important perforators of the ACOM, you will see that it's certainly not so simple. Anyone's mother can do it. But again, the medial stride arteries, or the central medial arteries, the lenticular strides, the perforators that are coming this middle cerebral artery. You see the anterior choroidal artery piercing the optic tract here, and you see the BCOM, which gives us the thalamic arteries, but we'll be talking about those separately. So let's focus on the striate perforators first: globus pallidus, putamen, caudate. A lot of people say that the lenticular striate arteries are also the ones that are supplying blood to the colostrum, the extreme and external capsules, but that's not true. Everything is bordered to the putamen. If you do a dissection, then you're going to see, and we're going to see that in a minute, you're going to see that the insular arteries, so the arteries of the insula, and that's obviously M3 branches, they're giving us very small vessels which are vascularizing everything up to the putamen, and the putamen and the rest, what is in the middle, that's vascularized by lenticular striate arteries. There's no overlap between these two. So when you have a lenticular striate infarction, not a middle cerebral artery, then you see that the putamen has an infarction and everything medial to the putamen, but the extreme, external, and colostrum are all being spared, as well as the insula. So that's one of the most important things to differentiate a lenticular striate from a M2 infarction, for instance. Now what you have to see is this front side, so about 1/3 of the head of the caudate nucleus, the putamen, and optic tract, everything that's here is supplied by small arteries coming out the Höbner. The rest, and also the superior side of the internal capsule is supplied by the lenticular striate arteries, and this place in between is supplied by some small perforators of the internal carotid, and especially by the perforators of the anterior choroidal artery. Now you don't hear too much about the anterior choroidal artery because that's a sort of, yeah, it's very difficult, and nobody dares operate there. It's not very, your patient can get hemianopia, hemiplegia, hemianesthesia for one wrong move of the bipolar, so it's something nobody really talks about. But it's really important, and the anterior choroidal artery true infarction, we're going to see a couple of those. There are a lot of reports in the literature which claim to show actual infarctions of the anterior choroidal, but which are not confirmed with angiography. You cannot say that that's an anterior choroidal infarction if you've not confirmed it with angiography, because the overlap between perforators at the level of the ICA, so the ones that are coming out of the top of the ICA, the T-bifurcation and the anterior choroidal is so big, and the variation is so big, that unless you confirm it with angiography, you may not call it an anterior choroidal infarction. So let's look at an angiography, because why not? So you see the top of the carotid, and you see here the Höbner artery and the medial striate or central medial arteries. If you look at it from a lateral portion, so this is the lateral angiography, you see here the anterior, this is the middle cerebral artery. When you're looking at an angiography, first thing you have to notice is where's the carotid. It's always very crooked. Where's the bifurcation? Which would be anterior, which would be middle. So you see this splitting into two M2 branches. So this is middle cerebral artery. You see here this bundle of fibers where the lenticular strides and the medial strides come together. That's at the level of the anterior perforated substance. There are three perforated substances. Anterior perforated substance, which we should talk about that like in one presentation alone, and then the lateral perforated substance, posterior perforated substance in the interpeduncular fossa. And what you also see here are two arteries. This one, which splits into two halves, and this one, which goes to the backside, is pecon, is anterior choroidal, splitting into the plexus and choroidal segments. If you wait about 2 seconds later, you can also see this even better in the lateral portion. Now, Takahashi is, so if you want perforators, you gotta remember a couple of names. Duvernois, he's about brainstem vessels. Takahashi, that's a neuroradiologist who does research in everything perforating. And Marinkovic out Yugoslavia, out Yugoslavia, so he's in Belgrade and he's at the Department of Anatomy. And he's the one that has literally researched everything perforating arteries so far. And he's shown us this case. So you see there's a, this is the anterior cerebral artery, and this is the middle cerebral artery, and there's a stop here, so there's an infarction. But what that helps us with is to see where Höbner comes out of the A1, A2 segment and is irrigating with the medial striate arteries. Because otherwise, if you'd be in a lateral portion, you see all the bile vessels in the medial cerebral arteries here. And because this patient had an infarction and they did an angiography, then you can see these beautiful vessels from the lateral side. Now, the lenticular strides, this is a recurrent artery of Höbner. This is A2 segment. This is a fenestrated ACOM variant. Now, the lenticular strides, what you need to know about them is they can be 2, 3, 4, up to 11. And they have a diameter about 100 to about 100 micrometers to about 2 millimeters. So if you're trying to do replantations, as Volovici does in Berlin, of bypasses and replant the lenticular strides, and you do an angiography and you see 2 or 3 branches which go out to the rest, then you can do a replantation. If the artery is big enough, you can do an antecide. This is just a embryological idea that you know this olfactory bulb and olfactory tubercle, that's by the subthalamus, and you see that there's an embryological anastomotic channel between the ACA and the MCA. So that explains that in the embryo, those two are connected. So all these striate arteries are coming together and coming out the same. So that's why if Höbner has more striate arteries, then there are less lenticular striates, and if Höbner has less arteries, then there are more lenticular striate arteries. So there's the embryological divide between these two. It determines how many striate arteries you're going to have. So this is the anterior perforated substance, and you can see Höbner. It comes out usually posterolaterally here of. Mostly on the front side, and you can see all these small arteries going to the superior side of the perforated substance, and then you see the lenticular striates. There's medial, inferior, and lateral. Nobody knows what the overlap between these are because there's not a very definitive study about that. Then you see the medial striate arteries, the ICA perforators, and the anterior choroidal perforators overlapping here at the level of the optic tract. The optic nerve has been reflected inferiorly, so there's a lot of overlap between these two perforators. What you see here is that usually the lenticular striates originate in the first 17 millimeters of the M1. So when you're dissecting M1 and you're looking on the medial side, because they're usually on the medial side to go basally, then the first 17 millimeters are the most important, because once you've passed those, the chance of encountering one of the lenticular striates is much less, and this you see here after the bifurcation of the carotid. You can have individual trunks or a trunk that splits, or even on the M2 you can still have one or two lone perforators which are obstructing your vision for aneurysm surgery. So again, the recurrent artery of Hübner coming here at the A1, A2 junction and giving us the central medial arteries, the lenticular striates, the medial, intermediate and lateral ones. And you can see that the more medial an artery is, the shorter it is in order to reach its distance. And then you can see that by the slope of the basal ganglia, because they're shorter here and they're much bigger here, and they need to reach the top of the caudate nucleus, the top of the putamen, the top of the internal capsule, and vascularize everything in that area. So this is from an anterior perspective, and this is from a lateral perspective. And again, from the M1, if you're looking at it, this is the area of the central medial arteries, head of the caudate, tail, and medullary body would be here. Putamen, and you can see the area of vascularization. Now, Takahashi does microangiographs, so he's placing a slab of brain which has been inserted with contrast, and you can see here very briefly the medial striate arteries, the lenticular striates, and the recurrent artery of Hübner. And again, in an axial section, because those were coronal sections, you can see medial striate arteries, Hübner, and lenticular striates going to the putamen. And what you should also note here is these are the insular arteries which are supplying everything all the way to the putamen. And putamen and the internal capsule are all supplied by lenticular striates. And these fine arteries is what you've seen in his film of the AVNs, because they're the small medullary arteries, that's what they're called. And this, if you see here, it's not very obvious. So this is the subpial microvascular network which is being formed here and which sends out medullary arteries all the way to the centrum semiovalum. And what you see here, it's obviously an infarction at the head of the caudate nucleus, just inferior to the ventricles. What for infarction is this? It's very well delineated. What do you think this is? Which perforators are we dealing with here? Yeah, it's a Hübner artery infarct. What about this one? It's just underneath the ventricle. It's involving the head of the caudate, a bit of the front of the putamen, and it's letting everything else be. It's also a Hübner infarct. You see this patient had an M1 aneurysm and all the beautiful perforators. After surgery, aneurysm disappeared, and so did the perforators. Dip, hemiparesis, hemianesthesia, it's a mess. So, small aneurysm, 70-year-old male, never coming out of a nursing home. What about this one? It's an infarction. It's a bit larger. It involves the whole of the putamen. It leaves the claustrum, the extreme and external capsule B. What is this? Lenticular striate infarction. Okay. What about this one? Is this also lenticular striate? This is central medial. It's also lenticular striate, but I said medial, intermediate, lateral. This is intermediate, just the intermediate section, so that the anterior half of the putamen is being spared. This one is the same. What about this one? Is this still lenticular striate, or is it something else? It's lateral, the lateral branches. And as we move on to more difficult infarctions, you see this is a lady who was 57, who came with hemianopia. She was disoriented. She was terribly disoriented and had hemianesthesia. And they seen this on the CT. What is this? What do you think this is? This doesn't look like the infarctions that we've had so far. So what is this? What do you think this is? anterior choroidal, and this is a real anterior choroidal. You can see it's going to the inferior side of the internal capsule. The more superior side is not so much affected. To the inferior side of the posterior cruise of the internal capsule, and obviously to the bit of the genicular body, lateral genicular body, and optic tract. So that explains your symptoms. And this was documented with an angiography, because otherwise you couldn't call it a true anterior choroidal. And this one as well. You can see the territory is very fan-like, very shape-like, and you can see here on the angiography there's something missing. It's the anterior choroidal. What about this one? It's very small here at the genu of the internal capsule. What do you think this is? It's an infarction of perforators of the ICA, and this was a consequence of an operation of a carotid artery bifurcation aneurysm, where a couple of perforators were sacrificed. They were in the tip, and this patient, he also did recover. And this one, you see here a rest of a supercellular meningioma with a sinus cavernous sinus invasion. They operated on this one, it was very big. They had to coagulate a couple of small vessels, and then the patient had an ICA infarction out of perforators, and he went home with a hemiparesis. So this would be about what an anterior choroidal artery infarction would be: posterior limb of internal capsule, the internal globus pallidus, genicular bodies. And anterior choroidal is so easy to mangle, especially if you're doing plexus papilloma surgery, intraventricular meningioma. You're saying, yeah, you can just coagulate everything there, and before you know it, you've coagulated a big chunk of anterior choroidal, and your patient is going home with this. So, anterior choroidal artery, it splits into two branches. It also gives up an uncle branch, Hypothalamic arteries and the Lenticular Strides. And this is its course. It's coming out of the ICA. It's crossing the optic tract medially, giving off all its perforators. Then it crosses again laterally with its two branches, plexus and choroidal, in order to go to the choroid plexus. And it also has extensive anastomosis with the lateral posterior choroidal artery. So if you're looking at it again alone, you have the globus pallidus and the inferior side of the posterior cruise of the internal capsule. Now, what you're seeing here, very short, is subependymal arteries. So there are arteries, or ventriculofugal arteries. Those are arteries which are coming out of a truncus of one of the choroidal arteries, which are going away from the ventricle in order to vascularize the wall. And you have the anterior choroidal, which vascularizes usually the temporal horn and the atrium, the lateral posterior, which vascularizes the atrium and the bodies, and the medial posterior choroidal, which vascularizes the ependyma on the underside. And here you see the fine medullary arteries going from pyovessels, from the M4 branches, pyovessels, microvasculature to the centrum semiovale, and the callosal branches, pericallosa, which are described in an article by Yasuji Tude, which is a must-read for everybody. Now, if we go more posteriorly and we look at PCAM, PCAM is one of the arteries which, where people say you can just coagulate it. Now, what you see, the PCAM gives off about 4 to 10, sometimes it's just 1 or 2 perforating arteries, which are called thalamotuberal arteries or premammillary arteries. We're going to see in a minute why. This is the mammillary body. And what you see at the apex of the basal artery, the thalamoperforators, which are going to this structure here, which is the posterior perforating substance to go inside the brainstem. And if you're looking, what we did for basal perforators, we're looking for thalamus. You see the PCAM, thalamotuberal, which are going to the ventroanterior and ventrolateral thalamic nuclei. You don't have to learn the nuclei of the thalamus necessarily, but if your patient is coming with very specific complaints, and you see just a very, very small area which is involved on the MRI, trust me, it's better to know these nuclei and know what you're doing, because sometimes you can, thalamus infarction when, as a result of your surgery, and then you want to know what your patient is going to go home with. So thalamotuberal, they're going to the anterior side. Thalamo perforating arteries from the basilar artery, which are going to ventrolateral and ventroposterolateral, so again laterally, and thalamo-geniculate, which are going to the back side, so a bit of the pulvinar, but you can see this small branch there, usually they spare the pulvinar, so the back side of the thalamus. They're usually going still here laterally, and then the real big branches, the lateral posterior choroidal, which is making a loop here and supplying the pulvinar, and the lateral posterior is going above the intermediate nucleus and supplying the lateral dorsal and posterior and anterior, and the ilioposterior choroidal artery, which is going above the third ventricle in its velum interpositum, and there out it gives up these branches for the dorsal medial nucleus and obvious for the pulvinar. So you can see a patient which with the coils, which had the basilar artery aneurysm coils compressing on the thalamo-perforating arteries. She got here the infarctions, but it spared the backside of the ventroposterolateral nucleus, and it also spared the pulvinar. But she had it bilaterally. Now, Dr. Tuare has told you many times about the artery of Percheron, but it's not really necessary that it's just one trunk. These are usually 2 to 4 trunks, and sometimes when the vascularization on the one side is less than that of the other, then they can compensate, but it's not necessarily an artery of Percheron. That's not always the case when you have bilateral thalamic infarction. That's I see it at our neurologists, our neuroradiologists, but I just don't agree. It's not always, bilateral thalamic infarctions is not always artery of Percheron. It's just not. So that lady, she probably had a bit of thalamo-perforating arteries supplying from the one side to the other. They can be very long and go to the other side of the thalamus. And then if you compress them here at the level of the posterior perforated something, then obviously we can cause bilateral thalamic infarctions. Again, what we've been talking about, thalamo-perforators, thalamo-tuberal, premammillary and postmammillary, and the anterior choroidal artery. These are the thalamo-tuberal at the PCAM. You see the third ventricle here, and again the thalamo-tuberal and the thalamo-perforators coming here from the apex of the basilar. The thalamo-perforators in the interpeduncular fossa and higher up, and the lateral and medial posterior choroidal going in velum interpositum, and lateral posterior choroidal going into the choroid plexus. Now, this is a thalamo-tuberal infarction. This patient was operating on a PCAM aneurysm. PCAM was closed, and she developed hemiparesis, hemianesthesia, and she got to a nursing home and not home. Another PCAM aneurysm, which was also clipped. PCAM was closed. Thalamo-tuberal infarction. You can't always close the PCAM. But what about this one? This patient had crossed or deficit, so fascia on one side and hemiparesis on the other side. This isn't thalamo-tuberal. What is this? It's a bit more to the back side. This thalamo-geniculate. This is a lady who had an infarction, 57-year-old. She would go to work at night, couldn't tell time, was always disoriented, would eat 20 times a day, and she got in a horrible state at the hospital. This is a bilateral thalamo-perforating infarction, but there was no arterial pressure on here. So this bilateral thalamic infarction, what you saw at the basilar apex aneurysm, but there was no arterial pressure on here. This is also thalamo-geniculate, sparing the pulvinar, so the backside of the thalamus is spared, and this is also a thalamo-geniculate, which is involving a bit more of the thalamus. I'm not going to go into the details of this photo about the hypothalamic arteries. What you should know is that the ACOM gives up the subcallosal arteries, and obviously then arteries here out, like the median perioptic artery or arteries for all the nuclei of the hypothalamus. And this is a pretty good photo to see why the thalamotuberal are premammillary and why the thalamoperforating are retromammillary, because this is a mammillary nucleus. But what you should remember is the ACOM aneurysms. They involve structures which are essential for your patient, hypothalamus. Your patient can get very bad hypothalamic consequences if you close the perforator and let out the ACOM. This is a photo of Duvernois, his atlas of brainstem vessels, and you can see how complex this all is. Anterolateral pontine arteries, lateral pontine arteries. You can see the lateral medullary fissure arteries and the arteries of the medulla itself. We're not going to get into this. This is a two-day course alone. But this is about the level of where the perforators are coming out of the basal artery and how they're involving this completely. And what you should know, again, due to the nature of the perforators in this area, one perforator will make hemiplegic. One. If you coagulate so much as just one of the PCA or basilar perforators, your patient will be hemiplegic. The septal area, this is a poorly understood area with the perforators of the ACOM. This is the hypothalamus on the other side, on each side of the third ventricle, and this is about the area of the anterior hypothalamus which they're supplying. Subcallosal branch, which is also supplying the inferior part of the corpus callosum. And I'm just going to leave you off with this. You can see here the basal vein of Rosenthal and the medial posterior choroidal artery going to the Volovici depositum and the collicular arteries, and the SCA trunks coursing around the mesocephalon and going to superior peduncle, the precentral vein, which you're sometimes coagulating when you're going to the pineal gland, transverse pontine vein, ICA, and just to show you the abundance of structures in this area, and hopefully we'll be talking about that some other time. Thanks.